Our next speaker is Dr. Dong Yijie from the Department of Ultrasound, Ruijin Hospital, Shanghai Jiao Tong University, School of Medicine, China. And Dr. Dong will bring us today ultra-resolution ultrasound from blood circulation to lymphatic flow. So let's give her a warm welcome.
Good morning, everyone. It's my honor for me to represent our team and report to you all on the clinical work that we have done using VINNO's Optimus 9E. I'm from Ruijin Hospital, Shanghai, China. And tomorrow, some of you will come with me into my hospital. Welcome, everyone. And today my topic is super resolution ultrasound from blood circulation to lymphatic circulation. Super resolution ultrasound system presents us with amazing images of blood vessels and the tumor microvasculature. Since SRUS breaks through the limitation of conventional ultrasonics. As we all know, the principle of SRUS is locating and tracking and accumulating microbubble trajectory. However, this is still only at the level of imaging the blood circulation. We are always thinking about how to expand clinical applications based on SRUS principles, since the body fluids are circulating flows. Vascular system, including blood vessel and lymphatic vessels, they communicate and exchange substances in the institution space through the capillary network and the capillary lymphatic network. As we all know, the lymph node metastasis or distant metastasis of tumor is also based on this interaction between blood and the lymph. Thus, let us to consider if we can alter the injection route of the contrast agents, we may have innovation of something new. We can inject contrast agents through 3 routes. 1, intravenous. 2, intralymphatic. 3, interstitial. Firstly, our work of SRUS in breast lesions, traditionally intravenous, showing microvascular in differentiation benign and malignancy. So let's see. This is 2 kind of breast cancer. One is for triple negative breast cancer. Another one is a non-triple negative breast cancer. And these beautiful images and with the precise quantitative parameters available that we can do a lot of analysis. So in our institution, we do 934 cases of breast lesions, combined intravenous SRUS, which show microvascular and contrast-enhanced ultrasound, and conventional ultrasound for predicting benign and malignancy. And we achieve an AUC of 0.948. It's very, very high. And also, intravenous contrast-enhanced ultrasound with microvascular SRUS in predicting molecular subtype of breast carcinoma, such as HER2 positive and HER2 negative, because these 2 kind of breast cancer, they have different prognosis. And also, we can use this to do intravenous contrast-enhanced ultrasound with also the microvascular SRUS in tumor proliferation for prediction of Ki-97. If this tumor is higher expression of Ki-97 or a lower expression. So we use Larson regression model selecting valuable feature of SRUS parameter and combine SRUS with contrast-enhanced ultrasound model for predicting HER2-positive breast cancer. And we also achieve a very quite good AOC because it's very hard. Small size of sample just have a lower accuracy. But maybe after several years of study, when we accumulating a lot of cases, then we will have higher diagnostic accuracy. The second part is the application of SRUS in sentinel lymph nodes of breast cancer. In this part, we study lymphatic circulation of breast-related lymph nodes. As we all know, the sentinel lymph node is the first lymph node that receives drainage from the primary tumor. So we can see in this movie, this is the movie we record when we just injected the contrast sonoview into the skin of the breast. We can see the contrast agents accumulated from the lymphatic tract and flow into the lymph node. It's very clear. It's totally different from intravenous contrast-enhanced ultrasound because it has a very clear background. There's no other things to disturb your observation. Then we will have dual vessel SURS imagings in sentinel lymph node. One is for blood flow using the traditional intravenous way. Another is the lymphatic flow. We use another way. Yeah. So this is the microvascular SRUS in lymph node metastasis using the intravenous way. And this is the microlymphatic SRUS of lymph node metastasis. We can see very clear there's a perfusion defect in the center of the lymph nodes. This is using a lymphatic way. Okay. We use these two ways of diagnosis, and we have our model that combine conventional ultrasound and microlymphatic SRUS, and we achieve our 0.844 diagnostic accuracy vs a conventional ultrasound. And this paper already published. This is our team. My leader is Dr. Zhou Jianqiao from Beijing Hospital. And this the third part, we talking about the SRUS in institutional lymphatic network of breast cancer. We know that the function of the lymphatic system is the drainage, the institution flow, and the lymph to maintain the fluid balance and participating in immune response and the surveillance. The institutional lymphatic network, this is a very important part, I think, and this is a future of research. We think the tumor invasion and the metastasis often occur at the level of the ILN. In this part, we do ultrasound-guided intratumoral injection. That means we injected the sonoviews. Of course, this is a diluted sonoview because if too many contrast agents, it will make too many, too many signals. That's just make confusions. So we dilated the contrast agents, and the dose should be quite a bit low. And caution aspiration should be blood-free, and no contrast agents should be detected within the blood vessel during the contrast-enhanced ultrasound. And then we found the SRUS characteristic of the institutional lymphatic network in breast cancer. It's lower density, lower proportion of the duct-like structures, and the lower velocity and the lower complexity. For lymphatic vessels that are structurally collapsed or non-functional within malignant breast tumors, SRUS may underestimate the number of lymphatic vessels. In contrast, the characteristic of lymphatic vessel in normal breast tissue are still preserved. The majority of lymphatic vessels within the malignant tumors are often destroyed and replaced by newly formed tumor stroma, which can lead to extremely higher institutional fluid pressure in the tumor. This may result in the lower flow velocity observed in the ILN in breast cancer. So in the benign breast tumor, just like fibroadenoma, the fine institutional lymphatic network structure is evenly distributed. The ductal branching is visible with larger ductal structures on peripheral branching into the smaller structures towards the center of the tumor. But comparing with the malignant breast tumors, the ILN structure is more destroyed and unevenly distributed, with duct-like structures mainly located at the periphery of the lesion. And the branching of the ILN is not distinct. So these are two movies of fibroadenoma and the intraductal papilloma, two cases. Very beautiful movies. The fourth part is the SRUS in institutional lymphatic network. In Hashimoto thyroiditis, we compare Hashimoto thyroiditis with non-Hashimoto thyroiditis. Also, we use this way. We injected the dilate, the sonovule, into the thyroid gland directly. And the sonovule flows from the institutional spaces into the lymphatic system. And we wanted to observe how the contrast agents spread in the thyroid parenchyma and the lymphatic vessels, and finally to the lymph nodes. These are the images of two groups. One is Hashimoto thyroiditis, another is a patient with no Hashimoto thyroiditis. And these four maps density, direction, velocity, and angles. And a lot of parameters we can have and accumulate to do the analysis. And we found some URM parameters that are different in the two groups. For example, the vessel distance, the vessel diameters in Hashimoto thyroiditis, and they are higher than in the non-HT groups. And the URM parameters, we have some preliminary results because we only do part of the cases. We already found something that different in the two groups because related to the pathological changes in the lymphatic system of the thyroid parenchyma in Hashimoto thyroiditis, especially manifested as tortuous lymphatic structures and the morphologically variations. And the parameters such as the vessel ratio, density, blood volume, and the perfusion index increased. And the visualization rates of lymphatics in the lateral cervical regions shows are significant increased in Hashimoto thyroiditis group. We think these results was caused by the pathological changes in Hashimoto thyroiditis because the thyroid follicular atrophy and the institution fibrosis and the gradually structure remodeling. And also in HT groups, the disrupt of the normal structure of the lymphatic network, thereby affecting its drainage function. So the visualization of lymphatic in the lateral cervical, the rates are different from the normal one. And the fifth part is the SRUS in lymphoma. In our hospital, because our hematology department is very strong, annually we have 1,500 cases of ultrasound-guided core needle biopsy of lymphoma in our hospital. Usually, lymphoma, we have CT, we have PET CT, but ultrasound have very lower chances to speak. But now, we have something to do. We do the microvascular SRUS in lymphoma, especially focused on the proliferation of NHL. And these are two groups. One is for the Ki-67 higher expression group. Another one is for the Ki-67 lower expression groups. And we found there's a lot of parameters that have significant differences in two groups, especially in the large vessel distance and the thinner vessel diameter in the higher expression groups. And also we have these two different ways, dual vessel SURS imaging in NHL. We use this way to show the lymphatic network of the lymph node. We injected contrast-enhanced ultrasound from the ultrastim lymph nodes and let the contrast agents flow into the lymphatic tract and then into the another lymph node that is downstream, so that we can see the whole procedure of a contrast-enhanced ultrasound to show the lymphatic one. You can see that this is the artery. There's no contrast-enhanced, but for intravenous, you can see the bubbles coming to the artery very quickly. So this has two ways to show different network. One is for the blood flow, another is for the lymphatic flow. We use this dual vessel SURS and to do something that we unable to do in conventional ultrasound, because we know that for B-cell lymphoma and T-cell lymphoma, usually for conventional ultrasound, it doesn't perform well in the differentiation diagnosis. But we have a lot of quantitative parameters, so we use this to do differentiation diagnosis. So we can see this is a follicular lymphoma. This is a lymphatic circulation, and this is the vascular circulation. And this is a T-cell lymphoma, also show the lymphatic microcirculation. And this is one case of the same lymph node. So we can compare, these are two different circulations. And we do 49 cases of dual vessel SURS, and we achieve our AUC of 0.8. I think it's a very good performance of this technique. So let's see, this is the same pictures at my presentation. How can we interpret these beautiful but complex images of blood vessels and the lymphatic, along with their rich quantitative parameters? What clinical problems can they help us to solve? And we think we need artificial intelligence to help us achieve this, because we have the imaging acquisition and the URM imaging. And after this, we can do ROI segmentations and the feature extractions. And finally, we can have the data mining and the modeling to help us to we establish this for ultrasound microvasculomics. And this paper already be published in European Radiology. And we think all of you can do something together so that we can have further research work. Because in China, you know, doctors are very rolling and rolling. We have to do not only clinical work, but also research work. And also later, we think the heterogeneity of tumor gives rise to impacts on the tumor microenvironment. So furthermore, we'd like to study of SURS-based habitat imaging. And this is another paper that we already Finally, we think the most beautiful scenery is still ahead. Thank you.
Thank you, Dr. Dong, for this inspiring presentation. And we hope that our collaboration will advance the clinicalization of the URM very soon.